Hello, welcome everyone to our Knowledge Success webinar on ensuring access to sexual and reproductive health in humanitarian settings, experiences and lessons from Asia. I'm Meena Arivanandan from Knowledge Success based in Malaysia. We will begin shortly. In the meantime, please continue to introduce yourself in the chat by sharing your name, your organization, and where you're based. Next. So let me share the agenda for the next hour. We will start with welcome and introductions. We'll have a look at some key insights in ensuring access to SRH during emergencies. We will also be following it up with panel presentations, followed by discussion and Q&A before we wrap up. Hope that sounds good to everyone. Next. We have with us a very great panel of speakers today who will be discussing strategies, insights, lessons learned, and recommendations related to ensuring access to SRH during emergencies. We look forward to hearing from Javeria Nisar, Advocacy and Communication Officer at the Forum for Women Development and Research, White Ribbon Alliance, Pakistan, Mr. Najib Samim, CEO of Afghan Family Guidance Association, and Dr. Pravin Shakya, Executive Director for Family Planning Association of Nepal. Next, please. But first, let's talk a little bit about housekeeping. If you haven't already, please change your Zoom name in the screen. Please note your mics are muted, so if you want to engage, please do so on the chat box. We look forward to hearing from you. And also during the session, if you have any questions, please type your questions in the chat box. We're here to learn from each other and also from our panel of speakers. Today's webinar is also being recorded, and we will be sharing the link shortly once we are done. Thank you very much. With this, I will hand over to Anne Ballard-Sara, our partnerships team lead on the Knowledge Success Project. Thank you.
All right, thank you, Meena, and hello, everyone. Good morning, good evening, good afternoon. I'm Anne Ballard-Sara, and I'm happy to be joining this webinar today to be talking about this very important and timely topic. I am the partnerships team lead on the Knowledge Success Project. And before we begin, I just wanted to share a quick background about the Knowledge Success Project for those who might be unfamiliar. So we are a 6.5-year global project, and we're funded by the USAID's Office of Population and Reproductive Health. The project is led by Johns Hopkins Center for Communication Programs in partnership with AMREF Health Africa, Busara Center for Health Economics, and FHI 360. Our objective is to ensure that people working in family planning and reproductive health can find, share, and use the knowledge they need to transform the lives of women, men, couples, and families everywhere. So we support learning and we create opportunities for collaboration and knowledge exchange within the family planning and reproductive health community. I'd also like to introduce our Asia regional team, including Meena, who you just met, and Pranab, who will both be facilitating today's session. So Meena is the Knowledge Success Asia Regional KM Officer, and Pranab Rajbandari is a Regional KM Advisor for the Knowledge Success Project. Brittany Getch, Sophie Weiner, and Aoife O'Connor also support our Asia regional activities. And that's just a sneak peek at our Asia regional team and the Knowledge Success Project. And now I'll hand it over to Pranab to get us started.
Thank you, Meena. Hi, everyone. What I'll be doing now is just giving some context to the topic today before we hear from our wonderful speakers. So the topic is ensuring access to sexual reproductive health during emergencies in humanitarian settings. Next slide, please. So just as a definition, emergencies, right, they can be defined as natural disasters. It can be natural or it can be human-made. Crisis or pandemic, like the one we've gone through in the last few years. It's a type of event or even a threat that produces or has the potential to produce a range of consequences, and it does require coordinated action. It is usually urgent, right? You have to immediately respond to the crisis and move that forward, but it also can be non-routine, right? So this is how an emergency is defined. And as you know, the world we live in right now with climate change, so there's an increasing threat of climate change, natural disaster risks, such as like droughts and wildfires, and increasing ocean salinity as well. And then from 2005 to 14, just because we're focusing on the Asia region, 40% of the world's natural disasters occurred in the Asia Pacific region. So a lot of burden on the Asia region on this, and the need for us to talk about this and get prepared for emergencies. And also, according to the UNHCR, by the end of 2023, 117 million people were displaced due to various reasons like conflicts, human rights violations, natural disasters, and persecution. And of these, 47 million were children, and an estimated 2 million children have been born as refugees between 2018 and 23. So there's a lot of different emergencies taking place around the world, and especially in the Asia region has a big burden on natural disasters and different disasters that we need to respond to, and especially as we're talking about SRH, how do we respond immediately to those different crises and face that. Next slide, please. Okay, so just a few general knowledge about access, like issues of challenges in ensuring access during these emergencies. So I think our speakers will be delving more into that, and I think we need to have a Q&A on this as well. But in terms of, as we know that when things go wrong, the supply chains, which are like meticulously set up, they get disrupted, right? Become services that are usually normally being carried out again can be inaccessible. So there's disruption of FPR services, and there's in terms of with disasters, the connectivity that we have that kind of joins the world together now, the digital connectivity might get lost or it might become poor because you won't get that level of connection. And then also in terms of there are challenges of, especially because this is an SRH issue, and in an emergency, there are a lot of pending things taking place. The leadership at the local level might be really, looking at different aspects of addressing the emergency at hand. And the SRH issue might not be a top priority, especially for the leadership and for the men in the community, right? And then, of course, in terms of a challenge that could also be part of the SRH access could be like the level of private sector engagement. Generally, a lot of the services are provided by government agencies, not NGOs. So private sector might again challenge. So these are right. And then also in terms of the sensitivity in terms of gathering FPR's data during emergencies might be difficult to do that. So those are general challenges that we might face during emergencies. And to address that, there is what you generally would know, that there's a minimum initial service package, MISP, which has been developed to address these types of crises. So I think we might be delving into that a little bit with our speakers. So this is just the context in terms of the emerging challenges of the different emergencies, especially in the Asia region, and maybe solutions for that. So thank you. I'd like to hand it back over to Meena to, I think, yeah, thanks.
Thanks so much, Pranav. We will now be moving into some rapid lightning talks with our speakers. If you're not familiar with what a lightning talk is, it's very short, incisive little presentations made by our speakers in which they provide their key insights. Please don't feel bad about it. If you want to know more, we can always speak with them later after the presentation. But remember, we also have a Q&A session and a discussion session, so you can ask any questions you want of them. These lightning talks are merely an appetizer, so to speak, for us to continue. So without further ado, the next slide, please. So as mentioned before, our speakers are Ms. Javeria Nisar, the Advocacy and Communications Officer for Forum for Women Development and Research. We have with us also Mr. Najib Samim, CEO of Afghan Family Guidance Association, and also Dr. Pravin Shakya, Executive Director, Family Planning Association of Nepal. They will be sharing with us their experiences in how they handle crisis situations in humanitarian settings, and also explore best practices and lessons throughout their experiences in the Asia region. Next slide, please. Ms. Javeria Nisar is a distinguished development professional leading the advocacy and communication portfolio at the Forum for Women Development and Research. She spearheads the World We Want project in partnership with CoMotion Social Change Agency and Ask Force members, aiming to foster a more equitable, healthy, and just world by empowering women, girls, and youth to influence global policies. Over to you, Ms. Javeria.
Thank you so much, Meena. Hello, everyone. Thank you for joining and being a part for this crucial event. For over 20 years, FWDR has been committed to promoting a more equitable, healthy, and just society for women and girls in Pakistan. Next slide, please. Any natural disaster heightens the vulnerability of women and girls, creating barriers to accessing reproductive and maternal health services. This is the second slide. Can you please? Yes. So this is what happened during the recent 2022 floods in Pakistan that placed 1.6 million women of reproductive age, including nearly 130,000 pregnant women, in urgent need of essential health services. Considering Pakistan already has one of the highest maternal mortality rates, the need for enhanced disaster response preparedness and risk mitigation is particularly critical in the areas of MNCH and SRH. In response to these health needs during the 2022 floods in Pakistan, we launched Reproductive Health in a Post-Flood Pakistan Listening and Learning from Women in Disaster campaign. This initiative aimed to address urgent SRH needs by amplifying the voices of women and healthcare providers, generating localized evidence to inform policymakers, and engaging decision makers to improve disaster preparedness. Building on philanthropic model of the Ask, Listen, and Act, which promotes locally led development by ensuring that the voices of local communities are prioritized, we reached out to over 2,500 women and girls, as well as more than 250 healthcare providers across 5 flood-affected districts in Pakistan to gather their key asks related to SRH. The top demands, as you can see in the table, were improved health services, availability of food and nutrition, family planning, WASH, and rehabilitation. So to effectively present this critical information, we developed a live dashboard titled What Women Want, Listening and Learning from Women in Disaster, consolidating these demands put forward by women and HCPs. We will be sharing the link to the dashboard in the chat box with you all. So listening sessions were then organized to facilitate open dialogue between selected women, healthcare providers, and district level authorities. So these sessions allowed women to identify solutions to their own issues, leading to immediate local action. So most of the needs were met at the district level through these sessions. For challenges requiring policy changes, we elevated those concerned to the provincial and national levels. Next slide, please. So during the disaster, the tendency is that the resources are often diverted from MNCH and SRH services towards infrastructure response and rehabilitation. That is why we choose to advocate for not only retaining, but increasing the allocation and availability of budget for reproductive health services. We acted upon the highlighted demands through budgetary advocacy, where we also supported the rehabilitation of local healthcare providers already present in the flood-affected areas, rather than relying on external resources, thus enhancing timely response. Technical support to the government was also provided for budget analysis, and the efforts ensured increased RMNCH and FP budget allocation, thus improving local disaster response and risk mitigation. Our campaign is indicative of how local responsiveness and preparedness are essential in emergencies, particularly in safeguarding the health of women and girls. So by actively asking and listening to the women's voices, we ensure our actions align with their most urgent needs, leading to sustainable solutions. Our Ask, Listen, and Act approach empowers women to take an active role in shaping response to crisis, demonstrating the strength of community-led development and fostering long-term resilience within the affected communities. Thank you.
Thank you, Javeria. That is truly insightful. We are really looking forward to know more about the dashboard. I think the rest of the participants are too. Without further ado, the next speaker, please, Mr. Najibullah Samim is the CEO of Afghan Family Guidance Association, where he spearheads efforts to enhance family planning, reproductive health, and overall well-being in Afghanistan. With over 25 years of experience in different national and international organizations in public health, development, humanitarian, and advocacy, he is dedicated to advancing the rights and health of Afghan families through comprehensive education, advocacy, and support services. Over to you, Mr. Najib. Thank you.
And thank you, Mina, for a good introduction. And thank you for giving us a chance to speak about the experiences from Afghanistan. And thank you for the organizers. Let me, I have a short presentation on the on our experience sharing from Afghanistan. So first of all, the context, I think, in Afghanistan, the provision of SRH services face significant challenges due to the sensitivity of the family planning and sexual and reproductive health, and that's because of the prolonged conflict and natural disaster. Afghan Family Guidance Association is a member association of IPPF and is also a lead service provider in SRH in Afghanistan, both in protracted and sudden onset humanitarian settings. AFGA delivers comprehensive SRH services across 11 out of 34 provinces of Afghanistan through its different service delivery points that include static clinics, family health houses, mobile clinics, and also community outreach midwife. The SRH services actually include RMNCH, HIV, STI, contraceptive, psychosocial support, SGBV, and these are also the integral part of our core funding, our core program, and also minimum initial service package during the humanitarian settings. Next slide, please. And on the practices during the disasters, what we have like the best practice. So whenever there is any crisis happening under the emergency, so we conduct first of all the need assessment, and this need assessment is conducted in collaboration with the WHO's led health cluster that also includes UN agencies and other aid agencies that are operating in that particular province. And then we also have a 6-member emergency response teams that are deployed in 2 main regions in Afghanistan, in Herat and also in Balkh in the north and west. Actually, to conduct the situation assessment, ground reporting, and also in response project planning. So this is like key for us to get the first-hand information from the team, from the area. And then strategies to respond actually to those crises. So strategies involves adapting mobile health teams, which is like the easiest way to reach to the affected population, and also deploying trained emergency response teams in order to respond based on their needs. And this ERT team is they act is a first people who will reach the area and assess the area and then get back to us with reports and what are like the needs. And then site selection is also because sometimes the disaster is huge, and so different partners, there are different agencies to respond, but then the site selection is, and also the allocation of duties and responsibilities is like a challenge during those crises. So site selection is mainly done through the health cluster and also the provincial public health directorates in coordination with them. And in terms of preparedness, we learned that reaching to those areas, those very remote areas from the center, from Kabul, it's always difficult, and therefore we established 4 warehouses in 4 of the main regions for commodities, medicines, medical items, RH kits, and winterization kits. So in order to be able to reach to the affected population very promptly. In addition to that, AFCA has 3 fully equipped mobile health teams always ready to be deployed. In addition to that, we also have like 14 MHTs in 3 provinces through the UNFPA funding. So they are also providing MISP in SRH services to the affected population. Safety and security, we always consider the safety and security of our staff, and we have different guidelines and SOPs we need to adapt. And in terms of M&E and reporting, since the health cluster is leading the effort, so all the stakeholders have to provide reports and updates to the health cluster in order to be compiled and then published on different websites and reports. So we are part of those reporting and M&E mechanism. Next slides, please. And in terms of achievement for the last like 2.5 years, there were different kind of crisis or emergency response projects that AFCA has implemented. That includes like a flash flood in Logar province, an earthquake in Paktika in Khost province last year, and also earthquake in Herat province, and also refugees returning from Pakistan. There was a bulk of them were coming back and they needed SRH services and MISP services, and also the recent flash flood in Baghlan province. So we have implemented a number of projects, and also in addition to that, these 14 MHTs that we say that these were deployed to the area. So altogether, a total of more than 800,000 various MISP and SRH services were provided to around 296,000 affected clients in those provinces through those interventions or responses that we had in those provinces. So this like a total figure of achievements of AFCA in providing the services. Next slide, please. And some key takeaways from our experience. So first of all, mitigating challenges across working the marginalized communities due to existing stigma, discrimination and misperception around SRH and SGBUs in Afghanistan. So that's like very sensitive. So you have to be very careful. So that's why we engage male and community leaders engagement is very crucial. So to involve them in the response. And then establishing referral pathways during those fragile setting and natural disaster, particularly with it in remote areas. So, and due to poor coordination and also knowledge about the services availability. So that is always a challenge, but accompanied referrals and budget vouchers for transportation to the first referral is highly advantageous. So this is like one of the key takeaways. And apart from that, community outreach midwife is a model for community-based SRH service delivery. Given that they are from the local communities, they know the norms and cultures, and they're well accepted by the local stakeholders, and providing services, including counseling at their doorstep and at their convenience and comfort. So they should be backed up with a specialist at first referral. So we have this model, comms model in across our programs, and they are also backed up with gynecologists and other senior staff to support them. And more importantly, local peer or volunteers. During the crisis, we understand that everybody is trying to be volunteer and take part in the response, and especially when they are from the affected population. So among the response team, that's a great advantages due to 2 reasons. That is one, to provide dual response purpose. One is scale and reach in ensuring safety of the response team with the community participation. So you will have from the beginning local support from the local affected population. And then diverse donor funding also, sometimes when there is a crisis, so in order to reach to the donors and get funding enough for the response. So sometimes it is like taking time, but in order to so you have to have diverse or at least some secure funding always available for timely response to the crisis. Next slide, please.
Please wrap up. Thank you.
Okay. So there are some photos that I wanted to show, but generally these were our experiences. And if any questions later on during the question ask questions, and I will respond accordingly. So thank you so much. Over to
Thank
you.
you so much, Mr. Najib. Really appreciate this. So let's move quickly to Dr. Praveen Shakya. Dr. Praveen Shakya has more than 20 years experience in FBSRH program development, management, M&E, and research and development. He's been undertaking different roles and responsibilities in various organizations. He was also with Marie Stopes International Nepal for more than 15 years and taught demography in Tribhuvan University for more than 5 years. He has published several journals and opinion articles focusing on advocacy, increasing access, awareness and utilization of FBSRH and public health services, empowering young people and women, and health strengthening, system strengthening. Over to you, Dr. Praveen.
Okay, thank you, Meena, and organizers for giving me the opportunity to present my presentation. Can you go to the next slide? Actually, the context of Nepal. Then I would like to say something about the Nepal. Actually, Nepal is one of the most prone countries for the floods, landslide, and earthquake, as well as the fires. EFPN, Family Planning Association of Nepal, established in 1959, has been involving in responding SRS needs of people affected by all these in different areas in different time. However, until massive earthquake occurred in 2015, which died more than 2,000 people died. It did not have any specific fund, project, and activities except providing some community-based SRS services through mobile camps, working together with the government and other stakeholders. At the time, Nepal government, as well as most of all the NGOs and INGOs, were also not much aware and equipped and resilience to provide SRS needs of the crisis-affected people. Moreover, COVID-19 has also provided lessons of increasing importance of equipping the government, communities, and development partners for prevention, preparedness, and resiliency to adjust our recovery readily from adverse effect of crisis in SRS needs. Realizing this, Family Planning Association of Nepal started working closely with the government and other stakeholders to respond SRS needs of crisis-affected people and to supporting an enabling environment for essential SRS services in humanitarian crisis, notably with the technical and financial support of IPPF from 2019. The International Planned Parenthood Federation, the IPPF humanitarian program, has initiated SPRINT project supported by DFAT, ASEAN, across 14 Indo-Pacific countries. Nepal is one of them, to address gaps in MISP implementation and improve health outcomes of crisis-affected population. Next slide, please. Minaji, next slide, please. The project was specifically implemented to meeting the essential SRS needs of communities affected by devastating earthquake of 6.4 magnitude in 2 districts on 3rd November of 2023. The districts were Jajakot and Rukum, west of Karnali provinces. The project was implemented for 3 months from 24th November to February 2024 to provide emergency SRS responses in those earthquake-affected districts. Indeed, the earthquake had severely affected livelihoods, educational opportunities, home, other assets, health facilities, and other infrastructure that had caused more than 158 deaths, 345 people injured, and 18,000 families affected, 12,000 families displaced, and 29,000 houses damaged. Immediately after the earthquake, the nearby branch team visited both districts and assessed the situation. Many people had faced disintegration of the families and other social network and were susceptible for mental and physical trauma, malnutrition, disease, long-term disability, and poverty. Women and girls were at particular risk of sexual and gender-based violence, as social and structural support system around them were almost collapsed. And because of all these, especially women and girls were at threat of risk of unsafe sexual relationship as well as sexual and gender-based violence. that may result in unwanted pregnancy, STI, HIV, maternal and child morbidity, as well as mortality. In order to address their SRS needs, FPN prepared itself to provide MISP and comprehensive sexual and reproductive health services, including sexual and gender-based violence, targeting to all children, adolescents, youth, women, and men. And we stopped because at the time we were very new and we didn't have any previous experience in MISP and helping the people in crisis. We communicated and coordinated with different level of stakeholders from central to local levels. Specifically, we coordinated with National Disaster Risk Reduction and Management Authority at national level and Reproductive Health Coordination Committee of Ministry of Health and Population at central level and Provincial Health Directorate and district level disaster management committees. And the municipalities and ward at community level, and formed and activated and worked together with UNFPA, UNICEF, Save the Children, Red Cross, and other stakeholders at the center as well as local level through the RS and GBB humanitarian response clusters, and had a series of meetings at national level as well as local level for shelter, food comprehensive areas, including sexual and gender-based violence. We continued at that time, we continued providing training on MISP as outlined by IAWG to local public and private service provider and managers. And we started providing comprehensive SRE services through mobile integrated camps. And we provided first-line support to sexual and gender-based violence survivors using LIVE's approach. And we referred sexual and gender-based violence survivors to OCMC. Thank you. Next slide, please. Through this project, we conducted 46 integrated camps, served more than 12,000 people, nearly 73% of them were female. We provided more than 68,000 services, more than 90% of them were SRS services. Nearly 8,000 people received family planning services that included 37,000 contraceptives, including 7 vasectomies and 13 first-time users. More than 600 women and girls received services on sexual and gender-based violence. Since our service providers were not trained on sexual and gender-based violence at that time, we used trained counselor from WOREC and CMC Nepal, coordinated by local government. While analyzing the service we provided, we found that the services we deliver impacted to about 374 unintended pregnancy, 1 child death, 151 unsafe abortions, and provided and supported to generate more than 2,000 or 2.5 thousand CYP. Next, please. Next slide, please. Now, I would like to share something about our experience and lessons. In our experience, the sexual activities and delivery of the babies that do not stop even in the crisis. Moreover, women's sexual and reproductive health needs do not suddenly stop or diminish due to emergency. In fact, they may become greater if not responded to their needs immediately. Also, they are more likely to be at threats to risks of unsafe sexual relations as well as sexual and gender-based violence that may result in unwanted pregnancy, STI, HIV, maternal and child morbidity and mortality. We have identified a big gap in service delivery and several barriers providing SRA services in humanitarian settings. For example, cultural and ideological barriers, data challenges, financial and resource constraints, and systematic and sectoral challenges. It is not only the SRS needs, but they will have also several other needs in crisis. So it is very important to go through the integrated response approach that's segregated approach. Then from this, what we learned is it is very important to focus on the preparedness activities developing humanitarian development nexus for marshalling support. And it is very important to localize humanitarian response to prepare for the preparedness and resilience, ensuring effective partnership and stakeholder engagement, inclusion of local government providers and community members and leaders. And it is
Dr.
very
Praveen,
important.
appreciate if you could wrap up. I'm so sorry.
Yeah, it's okay. I'm almost done. It is also very important to have a strong partnership and stakeholder engagement to support an enabling environment for SRH services. Thank you. Yeah, I'm done almost.
Thank you, Dr. Praveen. Appreciate this. We will now be moving into the next section, and I appreciate every one of you for adhering to the time as much as you could. Over to you, Pranav, to take over discussion and Q&A.
Thank you, Meena. Thank you to our panelists for sharing the important work you do in ensuring access to SRH during emergencies. I think what you have shared today from Afghanistan, from Pakistan, and from Nepal has been very insightful. And now we're very excited to have this opportunity to now chat and explore on your key messages that you have shared above. We have a number of questions that have been coming in, and I'd also like to inform our participants. If do you have any more questions for our speakers? If you do, please do drop a line in the chat. We are keeping a tally of that, and we'll keep asking the panelists these questions. So we will now proceed to a Q&A session. I think the first question that has come in is from Ong Thu Tun, and I think he asked the question is, in armed conflicts or wars, the health supply chain, including transportation of commodities, are restricted, and she's asking that can we address that as a human rights violation? So I think the question is in terms of in terms of human-made disasters, like violations of human rights, can those be seen as human rights violations? The question is open to all panelists if anyone wants to take a stab at it.
Let me start, to give my feedback on the question. And actually, during disaster and during conflict and war, basically the supply chain management is really a challenging job, and that's also very difficult to reach the affected population well in time. So this is certainly a challenge. But in Afghanistan, what we have experienced that. Sometimes during the winter season or during other conflicts, it is difficult to reach the affected population well in time. So that's why we have established 4 regional warehouses where we have stocked enough medicine and medical equipment, and also other winterization kits and other kits that are necessary to respond to those crises. So we have established those in those areas, and from there, when there is any crisis or any emergencies, so we can quickly reach to the area from those regional warehouses. And these are all supported by the UNFPA, and we have enough stock there in order to reach to the area well. But in terms of a human rights violation, so let's hear from other panelist member, but generally it's difficult and it's very challenging. But we have sorted that in that way. And also in addition to that, in order to understand the needs of the affected population, we have established, as I said in my presentation, that there are 6-member teams, emergency response team in those regions, where they can immediately deploy to the area and conduct the need assessment, and then report very quickly on the needs and also on the casualties, and also on what kind of responses that are needed from different aid agencies. And that reports and those assessments will also help AFCA and also other stakeholders to understand well on the situation and also on their needs. So that's quite helpful for us in Afghanistan. Over to you. Thank you.
Thank you, Mr. Noji. So I think the question was in terms of supply chain breaking down, and your answer was that in terms of preparedness and having warehouses and being able to assess needs earlier to be prepared for that. Thank you so much. So let me move on to the next question. The next question is for Mr. Javeria. So the question is from Ars. Afroz. The question is, you mentioned the Ask, Listen, Act approach you use in your campaign. How did the listening session you referred to influence local actions and lead to policy changes?
Yes, thank you for your question. So first, the listening session served as a crucial platform for facilitating the dialogue between the affected women and healthcare providers and the district level authority. So we focused on identifying and addressing reproductive health challenges. So this collaborative approach enabled us to find solutions for at least 50 to 60% issues at the local level. So we ensured swift action where possible through listening sessions. And for more complex challenges requiring broader policy reform, these sessions allowed us to take these concerns to the provincial and then to the national level. So this process not only ensured that the voices of the affected women were heard in the decision-making process, but it also led to timely and effective policy changes.
Thank you. Thank you so much. So
Thank you.
the next question is for Dr. Praveen. The question is from, I think, Rajesh Didia. The question is, what kind of service has been provided to women lived and experienced HIV and women using drugs, as well as to indigenous women in Nepal during crisis response? So this is for Dr. Praveen.
I think he is muted.
Oh,
Praveen, you're
Dr.
muted.
Praveen, I think you're muted. Can you unmute yourself, please?
Okay.
Thank you.
Now, regarding the HIV and HIV and STI, we provided especially the counseling and PIA test, and we referred then we did the HIV test also. Then I think in my slide I have shown that we did the HIV test of more than 300 women, but none of them were found positive. Then we have also referred some clients to the PrEP center and for the ARV services also. I think did I answer the questions? Then what was the
Right.
was
The
there
question,
PSP services also, or just STI services?
right. That the
I think
question
there
was,
were
how do
only
you,
STI services? Yeah.
right? How the question was, how do you provide services to women living with HIV and using drugs? So,
No, yeah.
okay,
Then
great.
one. I think we also mobilize the peer educators, like people living with HIV/AIDS, because we do mobilize the local community people. As a peer educator or frontline health workers, they know who are using who are the HIV people living with HIV and who are using the IDUs. Then that's why we have provided services to them also, mobilizing the local frontline health workers and peer educators.
Thank you so much. So engaging peer educators and frontline workers. So the next question is for Mr. Najib. The question is, how has AFCA been working with de facto authorities in the humanitarian situations, and what challenges do you face?
Yeah, actually, you know that women are not allowed to work in NGOs in organizations, but luckily the women working in the health sector and also education sector is allowed. So we have more than 300 women employees, mainly doctors, gynecologists, midwives. And they are operating and they are providing services across the 11 or 12 provinces that AFCA is working. And in terms of coordination with the Ministry of Public Health at the center, we have good coordination with them, and they listen to the needs and they listen to our approaches in our policies to implement. So we have good coordination with them, and also in terms of implementation of any project before going to the implementation phase. we signed MOUs with MOPH at the center, and also then later on coordination with the local health authorities and in each province. So we have good coordination with them, and so far we haven't faced any particular challenges in terms of implementation of the health activities. The MOU is like the first thing that we have to sign with them, and after having the MOU signed with them, so there is no problem later on. Of course, sometimes there are a little bit interferences, particularly in terms of, providing some packages like winterization kits and other, but those are manageable, and we didn't face any particular issues. Thank you.
Thank you so much, Mr. Najib. So let me move on to the next question. The next question is for Ms. Javeria. So the question is from Dr. Amara, and she asks, aside from creating your live dashboard, what other specific actions did the campaign take to improve disaster preparedness for SRH in the affected areas in Pakistan?
Thank you for your question. Aside from the live dashboard, one of the key action was to provide technical assistance to build the capacity of the government in budget analysis and effective allocation. So more consultative and online meetings were held with the government and key stakeholders to ensure that the dialogue on SRH and FP into health services start at the budget making stage. So this support helped ensure that the resources were directed towards the reproductive, maternal, newborn, and child health services and family planning services, strengthening our disaster response framework in the future. So additionally, our campaign emphasized the importance of the listening session approach as a key accountability mechanism. So in this way, we facilitated open dialogue between the women and the government officials, and that was shown. Its success was shown when these listening sessions were incorporated in the FP 2030 roadmap by our government. So by using local evidence, these listening sessions allowed for real-time action on community needs and ensured that disaster preparedness efforts were informed by those who are most affected. Thank you.
Thank you, Mr. Javeria. So let me move on to the next question. We have a lot of questions. The next question is for Dr. Praveen. So what are some insights on the sustainability of your interventions? Question is from Bayane Mekasa. To Dr. Praveen.
No, actually, at the time, we didn't have any, because at the time, we didn't have any plan for the sustainability and any plan for the sustainability, because it was very honest structure. As soon as we had a crisis, we went there with the flexible and honest structure program. And we implemented the program just only for the 3 months. That's why, but now the problem is we are now sustainable in capacity. Now, most of all our service providers have been trained in MISP and SGBB as well as CIMEX. Now we have a resilience to provide or continue the SRS services in any other areas whenever we are in need.
Okay, thank you. Thank you so much. So let me move on to the next question. So this is an open question for all the panelists. The question has to do with resilience. So the question is from David Ondongo. The question is, resilience is important for recovery of the affected population. What have you put in place to ensure impactful follow-up? So it's an open call. So please, anyone of the...
No, shall I start?
Please, yes, please.
Then actually, as I mentioned in my presentation, that we had developed a network and clusters, RS clusters, GBB clusters, as well as human response clusters also. And we have provided the trainings on MISP and some others, GBB and CIMEX to most of all the private as well as public service providers, so that whenever we are in now, we can meet and work in the coordinated approach, and we can collaborate it. And that have definitely increased our resilience to support the SRS needs.
Okay, thank you. Thank you so much. So let me move on to the next question. So which is for Ms. Javaria and for Mr. Najib. So the question is from Chetra Joshi. The question is, in humanitarian settings, there is a chance of gender-based violence. The question is, so do you have any checklists to assess the GBV in the settings that you work in?
Yes, thank you. So in our campaign, we always try to have create an inclusive and safe space for women. So before asking them, we always take their concern and we take them into that safe space. And there is always a prerequisite for asking women. So if they are encountering any problems or issues at home, and this is done off the record so that pertaining to the guidelines of our project. And we always make sure to ask them and ensure that they would be provided that safety and that safe space for them.
Great. Thank you so much. Thank you. So let's move on to the next question. We're running out of time for the Q&A. The next question is from Alexandra, and the question is to everyone. What lessons learned and good practices do you have for the inclusion of marginalized groups, such as people with disabilities and LGBTQ people?
Then, shall I respond? Yeah,
please. Yes, please.
Then actually, I mentioned that it's very important to mobilize the local people. In the forms of peer or volunteer, whatever possible, it is very important to ensure the inclusion of the local government, local political leaders, as well as local communities.
Okay. So engaging local communities is...
Yeah.
Okay. So anyone else on the panel?
No, I think, I don't know whether I said this or not. It is also important to include the people-led organizations. Like suppose if you want to work for the PLHIV, then we need to ensure the inclusion of the representative from PLHIV group. Similarly, people with the disability group and adolescents or female sexual worker, whatever we want to address, whatever we want to address, we need to ensure the inclusion of people from those groups.
Great, thank you. So I think I heard you're saying more in terms of engagement rather than just representation, right?
Yeah.
Engaging the... Thank you. So in interest of time, we still have a lot of questions that we need that are coming in. So I think we will try to get those answered from the speakers. Unfortunately, we are now running out of time. So just in summary, again, I would like to thank the speakers for your insights and answering questions, like from your diverse perspective. And so in terms of what I heard, so in terms of coordination seems to be a very key lesson learned in terms of coordination beforehand, coordination during, and to get the community engagement and prepare with the private sector, like engaging the marginalized groups, right? So the coordination seems to be a very good learning, as well as in terms of being prepared. So I think, as I heard, the preparedness, even in your part, took place over time as well. So those, and they're like having resources in need that you can use, and also like increased need of resources to use during the emergencies to address issues. So I think we will conclude the Q&A session, even though we have a lot of questions. We will try to get those answered afterwards. So thank you so much for your insightful answers. And so I think I'd like to wrap that and hand it back over to Meena for the wrap-up session. Thank you so much.
Thanks so much, Pranab. Thank you, speakers. You have been really gung-ho about this. I know many of you have many more questions unanswered, but we hope that this conversation continues. So please feel free to reach out to the speakers as well to answer your questions. Next slide, please. So the next slide, please. Before we close, we want to draw your attention to the KM Roadmap for Public Health Emergencies. It's part of our training module on the KM training package in our Knowledge Success website. Next slide, please. We also have a very robust community in FP Insight. Do join our community for access to a collection of resources on sexual and reproductive health in emergency settings. Next slide, please. Our panel speakers have also shared additional resources. Please feel free to go into it and check out the live dashboard and the videos on the humanitarian work that AFCA is doing. Next slide, please. Do stay connected. Sign up for our email and newsletter updates where you will have updates for events and activities. Do join the FP Insight community or contact us directly at any point in time. We will have a short survey at the end of the session, so please do help us improve by giving us your feedback. Thank you very much. Next slide, please. I'd like to quickly just say thanks to the entire Knowledge Success facilitation team for their excellent facilitation. I'd also like to thank the panel of speakers for being very, very amenable and very generous with their time. Thank you so much, speakers. Really appreciate it. Thank you.